Let's go over the warm-up review. First question, what are some medications that have a low therapeutic index? So the mnemonic we used was some drugs with low therapeutic index. So the S is for seizure drugs, D is for digoxin, W is for warfarin, L is for lithium, and T is for theophylline. Next, what bone disorder results from excess PTH, or parathyroid hormone? Well, it's osteitis fibrosis cystica, which is also sometimes called von Recklinghausen disease of bone. And the last question, what are the layers of the epidermis? So the mnemonic for this was, come, let's get sunburned, for stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and then stratum basale. And then below the epidermis, you have the dermis. Now we're all warmed up for the lecture.
Welcome to our next Step 1 video. In this lecture, we'll be covering uterine pathology. But before we start talking about pathology, let's go over some basic info about the uterus. The uterus is composed of 3 layers. The outer serosal layer is called the perimetrium. The middle layer is the myometrium. This is the smooth muscle layer, and it's important for generating strong contractions during labor. And the innermost layer, the layer that lines the uterine cavity, is the endometrium. This is the layer that grows every month in anticipation of supporting a pregnancy. It's also the layer where the majority of uterine cancers begin, growing in response to unopposed estrogen. The endometrium itself is composed of 3 layers. This is in your study guide. The stratum basalis is the base layer and is not shed with menstruation. The superficial layer is called the stratum functionalis, and that's the layer that's shed every month. It's composed of the stratum spongiosum and the stratus compactum. Remember that during the first half of the menstrual cycle, the increasing levels of estrogen stimulate the endometrium to proliferate and grow thicker. And then after ovulation, the corpus luteum produces more and more progesterone, and progesterone inhibits endometrial proliferation. Progesterone promotes secretory changes that prepare the endometrium to support implantation and a pregnancy. But if pregnancy does not occur, the corpus luteum degenerates, there's a drop in estrogen and progesterone levels, and without that hormonal support, the functional layer of the endometrium is shed. On the left is a section of endometrium from the proliferative phase, the first half of the menstrual cycle. You can see that the glands are straight and tubular, and the stroma is dense. Then in the middle is a section from the secretory phase, the second half of the cycle. Here, the glands are dilated and tortuous, almost corkscrew-shaped, and the background stroma is loose and edematous. And finally, on the right, is a section of menstrual endometrium. You have fragmentation of the glands, and you can see that the stroma is breaking up. So it's normal to have endometrial proliferation in the first half of the cycle, and remember, that's driven by estrogen, but then the second half of the cycle, this proliferation is opposed by progesterone. But what happens if you have too much estrogen stimulation? Well, like we mentioned before, that can lead to endometrial hyperplasia, which is a precursor to endometrial carcinoma. So the problem is excess, unopposed estrogen. The risk factors for endometrial hyperplasia are anovulation, so for example, patients with polycystic ovarian syndrome are at risk. Ovulation needs to occur in order for the corpus luteum to form and start producing progesterone. So people with anovulatory cycles get stuck in that estrogen-dominant proliferative phase. Increased estrogen production is a high risk factor. This could be due to an estrogen-producing tumor, like a granulosa cell tumor, or obesity. Remember that adipose tissue contains aromatase that can convert androgens to estrone. And then, of course, too much endogenous estrogen can do this. An example of this is the hormone replacement therapy for the treatment of menopause. That's why we always give progesterone along with estrogen if a woman has a uterus. You never want to give unopposed estrogen. The problem with endometrial hyperplasia is that over time, endometrial carcinoma can develop. Endometrial carcinoma is the most common gynecologic malignancy in the United States. In developing countries, the most common is cervical cancer, but in the US, since we have good screening for cervical cancer, endometrial cancer is the most common. It occurs mainly in postmenopausal women, and the peak incidence is ages 55 to 65. The 5-year survival rate for endometrial carcinoma is good, 80 to 90%, if we catch it in stage 1, so we try to catch it early. There's no screening, but many patients will present early with irregular bleeding or postmenopausal bleeding. So to make the diagnosis, we do an endometrial biopsy, a simple office procedure where a pipelle is inserted through the cervical os until it comes in contact with the uterine endometrium, at which point the pipelle is used to suck out a small piece of the endometrial lining out for analysis. This is endometrial hyperplasia. On the left, you have the gross specimen, and it's noted that the endometrium is thick and hyperplastic. When you look under the microscope, you see that there are a lot of dilated glands with not very much stroma in between them. And then, this is endometrial carcinoma. You can see some glands, but I think you can tell they're disorganized in disarray. Let's switch gears now and talk about endometritis. Endometritis is an inflammation of the endometrium, usually due to an ascending infection from the vagina. So it's often polymicrobial. Acute cases are seen postpartum, especially after a C-section, or abortion if there are retained products of conception. However, chronic endometritis can occur in the context of pelvic inflammatory disease or in cases of retained foreign bodies. Chronic endometritis is characterized by the presence of plasma cells in the endometrium. Since endometritis is often polymicrobial, treatment is with broad-spectrum antibiotics. For example, postpartum endometritis is usually treated with gentamicin plus clindamycin. Do not confuse endometritis with endometriosis. You are much more likely to be tested on endometriosis. Endometriosis is a condition where endometrial tissue is found outside of the uterus. The endometrial implants are still hormonally sensitive and functional, so they can still bleed every month. And depending on where the implants are, this can cause a lot of pain. Furthermore, there's a lot of inflammation within these implants, and this can eventually lead to fibrosis and adhesions. There are a few theories regarding how endometriosis develops. One is via retrograde menstrual flow through the fallopian tubes, which would mean that the endometrial cells are spilled into the pelvic cavity and then implant within the bladder, serosa, bowel, etc. Another is from metaplasia of the coelomic epithelium, the germinal epithelium. And then another spread is vascular or lymphatic spread, and even abnormal stem cell trafficking. The real answer may actually be a combination of these different theories. So where can you find endometriosis? Well, it's usually in the pelvis, but it can be anywhere. And totally paradoxically, it can be found in men. But for our purposes, let's focus on where it's found most commonly, which includes the ovaries, followed by the uterine ligaments. But it can also affect the bowel and the bladder. And uncommonly, you can even have endometriosis in the lungs, bone, or even the heart and brain. Pretty much anywhere. But definitely know that the most common location is in the ovary. And this can sometimes lead to development of large ovarian cysts that fill with blood, which are called endometriomas. These endometriomas are also known as chocolate cysts because if you cut into one, it will be filled with old thick blood that looks like Hershey's chocolate syrup. The symptoms of endometriosis will depend on the location of the implants. The most common symptoms are dysmenorrhea, painful periods, pelvic pain, and dyspareunia, pain with intercourse. Infertility is another common complaint. And you can also have dysuria if the bladder is involved, or dyschezia, pain with defecation, if there is involvement of the bowel. The gold standard for the diagnosis of endometriosis is laparoscopy, looking at the implants with your own eyeballs. Unless you have a large endometrioma associated with an ovary, it's nearly impossible to diagnose endometriosis via imaging. That way, you can actually see the endometrial implants. These are often described as having a powder burn appearance, and then you can remove the tissue and send it to the pathologist for confirmation. So in that way, laparoscopy can actually also be therapeutic. If you see a powder and burn lesion, i.e. an endometriotic implant, you can use your electrocautery to fulgurate the lesions, a word that means to destroy tissue with electric current. That is a great option for implants on peritoneal surfaces or on uterine ligaments. Your other first-line treatment options include NSAIDs and OCPs. Progestins are also an option. They inhibit growth of endometrial tissue. For more severe cases, you might use a continuous GnRH agonist like leuprolide. We'll talk about leuprolide in more detail later in this lecture. And then danazol is another pharmacologic option, albeit one that's not used very often. Surgery to remove the ovaries is also used in women who have completed childbearing. This works by removing the majority of the endogenous estrogen production by women, and once the estrogen levels fall, the endometriosis implants have nothing left to stimulate them. But what happens when conservative management fails in someone with recalcitrant pain in an area like the bladder? The only option left is complete resection of the lesions, which in this case means partial bladder resection, which then must surgically be reapproximated to close the defect. Yeah, endometriosis can be pretty rough. So back to pharmacotherapy, what is danazol? Danazol is a synthetic androgen. It acts as a partial agonist at the androgen receptors, so it provides negative feedback at the hypothalamus and pituitary, and that inhibits release of FSH and LH. Uses include endometriosis, fibrocystic breast disease, and hereditary angioedema. Danazol is actually quite effective at treating endometriosis, but it's not used very much anymore because of its side effects. Specifically, danazol can have masculinizing effects like acne, hirsutism, and deepening of the voice. It can also cause weight gain, decreased HDL levels, and hepatotoxicity. And danazol can also cause hot flashes. So that's danazol. Be a little familiar with it. Let's move on to adenomyosis. You can think of this as endometriosis of the myometrium. So the endometrial tissue extends inside the smooth muscle layer of the uterus. This causes the uterine wall to hypertrophy and become thicker. And so the uterus is often enlarged and globular on physical exam. And it's often tender to palpation as well. Symptoms of adenomyosis include menorrhagia, dysmenorrhea, dyspareunia, and pelvic pain. And then the definitive treatment is hysterectomy. Next, let's move on to leiomyomas. Leiomyomas are more commonly known as uterine fibroids. NBME refers to them as leiomyomata uteri in their STEP questions, but no one in real life calls them that. These are benign tumors of the smooth muscle of the myometrium. They're monoclonal, meaning that each one arises from one cell, and they're extremely common, the most common benign tumor in women. Some estimates are that 70 to 80% of women have leiomyomas. Fibroids are hormonally sensitive. They grow bigger in response to estrogen and progesterone. So they mostly affect reproductive aged women, and they do tend to shrink a little bit after menopause. These are round, firm, well-circumscribed tumors, and they tend to occur in multiples. On histology, you'll see a whorled pattern of smooth muscle cells. That's characteristic. So what kinds of symptoms will women with leiomyomas have? Well, actually, most are asymptomatic, but menorrhagia is the most common symptom. Dysmenorrhea is pretty common as well. Pelvic pressure or discomfort can occur if the fibroids are large enough. You can have acute pelvic pain if the fibroid is on a stalk and that stalk twists on itself, cutting off the blood supply. Or sometimes a fibroid will outgrow its blood supply and degenerate, and that will cause acute pain as well. Some women can have infertility or miscarriages depending on the location of the fibroids. If you can imagine a fibroid that starts within the myometrium and instead of growing outward towards the serosal layer, the fibroid grows inward, which can distort the endometrial lining and even break through into the endometrial cavity. This, as you can imagine, is disruptive to pregnancies trying to implant onto a distorted and suboptimal endometrial lining. And then another possible symptom is urinary frequency. Why is that? As you can see from this image, the bladder lies anterior to the uterus. So a large fibroid on the anterior surface of the uterus can compress the bladder and cause urinary frequency. Fibroids can usually be diagnosed by physical exam, followed by an ultrasound for confirmation. On exam, you'll feel a non-tender enlarged uterus with irregular contours. I don't think we need to go in too much into the management of fibroids, but I will mention that hysterectomy is the definitive treatment. Sometimes myomectomy, or removal of only the fibroid, is attempted, particularly if infertility is the reason for surgery, or if the patient has not completed childbearing. Prior to surgery, we can give leuprolide, that GnRH agonist, in order to shrink the fibroids and make the procedure a little easier. And the smaller a fibroid is, the higher chance there is that the surgeon can perform the surgery through a minimally invasive approach, which translates to quicker recovery times and reduced hospital stays, all good things. Leiomyomas are benign and they really don't become cancerous. Leiomyosarcomas, on the other hand, are malignant tumors arising from the myometrium. This is in your study guide. These are rare and are thought to arise de novo, so not from leiomyomas. For your test, you should suspect a leiomyosarcoma in a woman with a rapidly enlarging uterus. This actually isn't how these patients normally present. Usually they present with vaginal bleeding, but a rapidly enlarging uterus is the classic description. Remember, a huge fibroid does not equal cancer. Speed of change, not ultimate size, is what's key. So when Sally with a 6 centimeter fibroid at age 35 comes in 10 years later with a 12 centimeter fibroid, it's not concerning. But if Sally were to show up at age 37 with that 12 centimeter fibroid, that is far more worrisome. I mentioned leuprolide as being a treatment option for both endometriosis and fibroids, so I want to finish by talking about it in a little more detail. Leuprolide is a GnRH analog, so it works by binding the GnRH receptors. Remember that normally the hypothalamus releases GnRH in a pulsatile fashion, and the GnRH then stimulates the anterior pituitary to release FSH and LH, which act on the ovaries to produce estrogen and promote ovulation. So when you give leuprolide, it's an agonist, right? So it binds to the GnRH receptors. And at first, you get a big release of FSH and LH, and therefore estrogen. But if you keep giving leuprolide after that initial flare, there's downregulation of the GnRH receptors in the pituitary. So then FSH and LH are not released, and there's a subsequent fall in estrogen levels. So basically, given continuously, leuprolide acts like an antagonist and produces a hypogonadotropic state akin to menopause. As you may have guessed, the side effects of leuprolide are basically the same as the symptoms of menopause: amenorrhea, hot flashes, decreased libido, depression, and bone loss, which is an important one to know. So when would you use leuprolide? This is in your study guide. It's used to treat leiomyomas, but just to shrink them before surgery, endometriosis, central precocious puberty, and advanced prostate cancer. And for those 4 uses, it's given continuously. Leuprolide is also used to treat infertility, and there are 2 different ways that leuprolide is used for this. Most commonly, as part of in vitro fertilization, leuprolide is given continuously in order to suppress the intrinsic release of gonadotropins so that you can better control the cycle. So basically, you block the patient's intrinsic hormone production and then give them a surge of gonadotropin to trigger ovulation exactly when you want. The other way is to give leuprolide once. It'll cause that big release of FSH and LH, and that can trigger ovulation. Leuprolide actually has too long of a half-life to be used to mimic the physiologic release of GnRH. There is a synthetic GnRH that you can use for that, but not leuprolide. And actually, you need a medication pump for that synthetic GnRH because you have to give it every 60 to 90 minutes if you want to mimic the hypothalamus. But again, that's beyond step 1. Here's what you need to know. You need pulsatile release of GnRH to have an ovulatory cycle. And leuprolide is a GnRH agonist. But if you give it continuously, you'll get antagonistic properties because of the downregulation of GnRH receptors. That's it for the lecture. Now it's time for the end of session quiz. Let's go through the answers together. First question: what causes endometrial hyperplasia? Prolonged stimulation by unopposed estrogen. So risk factors for endometrial hyperplasia include anovulation, for example, patients with polycystic ovarian syndrome, increased endogenous estrogen production, like with a granulosa cell tumor or because of obesity, and then unopposed exogenous estrogen, like hormone replacement therapy with estrogen only. What uterine pathology matches each of the following descriptions? Excess unopposed estrogen is the main risk factor. That's endometrial hyperplasia and carcinoma. Characterized by plasma cells and the endometrium, that's chronic endometritis. Causes cyclic pelvic pain, plus or minus bowel and bladder symptoms. Think endometriosis. Menorrhagia plus non-tender enlarged uterus with irregular contours, that one is leiomyoma, aka fibroid. Menorrhagia plus tender enlarged globular uterus, that's adenomyosis. Malignant tumor that arises de novo from the smooth muscle of the uterus, that's leiomyosarcoma. What is the mechanism of action of leuprolide? Leuprolide is a GnRH agonist. It binds to the GnRH receptors in the anterior pituitary, initially activating them and leading to the release of FSH and LH. However, with chronic use, leuprolide causes a downregulation of the number of GnRH receptors, leading to decreased secretion of FSH and LH, thereby producing a chemical menopause. Let's do the rapid-fire facts. Most common benign tumor in women: leiomyoma. Chocolate cyst of the ovary, think endometrioma, or endometriosis of the ovary. Powder burn lesion, that's also endometriosis. Okay, that's it for this video. See you next time.